Jacques.
Hi, how are you?
Very well, thank you. I just want to quickly see. Okay, great. I am co-host, so that's perfect. Cool. Because I think I'm going to control the slides, although I see that I think John has got the slides up. John, are you there?
Hey, I am here, but Gerdine has got the slides as far as I understand.
Okay. Let's see if Gerdine is there. Otherwise, I can load the slides as well. I know she wasn't sure if she was going to be able to make it.
Hi, Prof. I'm here. I gave you slide control. We can check if it works. Otherwise, I can go out and you can take over.
Ah, it is working. Great.
Perfect.
I've never done that one before. Brilliant.
Continuous improvement.
I tell you. Fantastic. Okay, let's see. It's 4 o'clock on my watch. It may not be 4 o'clock on everyone's watches, so maybe you can just wait 1 minute and then we'll get going.
Werner, I want to ask it, is it possible to set up a poll? How do one set up a poll on Zoom? Can one do it?
Yes, you can.
From this side.
Jacques, I think I will have to do that.
Okay.
Probably. So you can send me your questions.
Okay, I'm going to forward you it's actually just one short poll that will come after the cases that Gideon will present. So I will forward that to you just now.
Okay.
Good. I think we're going to get going. So welcome everybody and good afternoon. Great to have you all here. I'm sure lots of people will still join as time goes on. But yes, it's my great pleasure to have the Free State team on the line today. And what an interesting topic. I was fascinated when I saw this for the first time. Who would have thought extracellular matrix proteins is important for consultative hematology? Now, this is exactly the type of topic I like. I hope everybody else likes it as well. And I will ask Jacques to introduce our speaker in a minute or two. So just as a reminder that the sessions are recorded and the recordings are available on the Blood SA website. I can strongly recommend, if you want to have a quick sneak peek, to go and have a look at the website and the resources there. There's lots of stuff. It's growing by the day and the Blood SA team is doing a phenomenal job on that. So we're very proud of them and everything they've done. Please take part. This is like, you know what a good Afrikaanse bring en braai is. Everybody brings something to the table, which can be a question, a comment, a thought. Throw it into the chat box, put up your hand. We'd be very happy to take any questions or comments. For the attendees who are South African registered healthcare workers, your CPD points or attendance will be automatically submitted to the Health Professions Council. But please note, to get that point, you need to be in the room for 60 minutes. That's how the system is set up, and that's how the point system works. So we can't do anything about that. That's just one of those things. If you're from elsewhere, you need a certificate or some proof of attendance, please contact Melanie Davids at the email address on the screen. This is our team that runs the show. Prof. Stelverberg is the deep dive team leader. She, together with Gerdine, who's on the line, co-hosting this, who's our national training coordinator, and Melanie Davids, the CPD administrator and UCT hematology secretary. Thank you all to all of you for fantastic work done once again. Then I am going to hand over to Jacques. I think many of you will know Dr. Jacques Malherbe. Jacques is the head of clinical hematology at the University of the Free State, and one of the people that I was very blessed to work with for quite a while during my time there. and one of the people who trained when I was there that I'm super proud of, and all the things he does. I have to, fun fact about Jock, he finished in the top 10 in the recent Epic together with his teammate. I can't remember which category exactly. Was it for teenagers, Jock, or
I wish in the masters category.
Masters? That's the word. That's the word. So congratulations, Mark. Jock is a man with extreme abilities and tenacity. So yeah, wow. If I just think of the Epic, I am thinking of sitting down. So Jock, over to you. Thank you once again for putting today's session together, and I leave the leadership of the rest of the session over to you. Thank you very much.
Thank you, Vernon, and thank you for the kind words. So today it's a pleasure to introduce to everyone Dr. Gideon Ruder. He's our current recipient of the Sasha's Bristol-Myers Squibb Foundation educational grant, and he started training in our unit from January of this year. He's born and bred in Bloemfontein, and he completed his schooling and undergraduate and postgraduate training here at the University of the Free State, where he qualified as a specialist physician at the end of last year. Outside of work and family time, Gideon said he's unable to ruminate over extracellular matrix molecules beyond a few fleeting moments before system failure sets in. So Gideon is the only speaker. He's going to present his topic. It's quite an interesting discussion, and it sounds like something far-flung, but the topic is covering an important topic which we are, as clinical hematologists, are often consulted about. So without further ado, I will hand over to Gideon. Gideon, I think you can share your slides and then start your presentation.
Thanks for the kind introduction, Dr. Malherbe and Prof. Lowe. I don't know if my slides are currently visible.
Yeah, we can see them, and you're audible loud and clear.
Perfect, thanks. Thanks for the kind words of introduction. Please see my disclosure and disclaimer. I must say, on Prof. Lowe's words, I became a bit more nervous that I might have set the bar a bit beyond me, but let's hope my lack of insight into extracellular matrix molecules doesn't come to bite me too much. So the topic of today, fortunately, will not be centered too much on extracellular matrix proteins, but rather a clinical topic to which we will journey shortly. The reason I say fortunately, it's not because extracellular matrix molecules and proteins are necessarily unimportant. It's just, as a pre-grad med student, I vaguely remember these times as nap time or meme time or any other time except for paying attention time. This has just always been a bit beyond me, maybe too complex. So yeah, my foundational knowledge is a bit shaky on it. So I won't be teaching anyone foundational knowledge on this, but hopefully I can tie it into the discussion. And I see not too many people have checked out of the session, so I assume that this astute audience does not share my proclivities as a pre-grad student. I'll start off with a few cases, as Dr. Malherbe said. These two cases were quoted from case reports that were published in the Annals of Internal Medicine in 2002. Our first case will actually be the second patient from this series. A 60-year-old female who had cardiac surgery, including aortic valve replacement surgery. I assume a mechanical valve of sorts. She received actually fractionated heparin. I think I made a typo there. She received enoxaparin pre-operatively. She had an episode of amnesia during recovery on day 4, which they don't make too much of. And then she was given warfarin on discharge. A month post-discharge, she presented again with a DVT and an INR of 4.2. So I've put these questions in. I think it's just to probe the clinician within us as to what went wrong, what is going on, what to do. So from my opinion, I would think warfarin time in therapeutic range in our center at least is pretty poor. I would guess in many others, and I don't know about the center where the case is based on. So perhaps that's the case. So this 4.2 is maybe an outlier. There have been times of the patient not really being anticoagulated. Perhaps there's factor C deficiency and the bridging was suboptimal. Ultimately, it is pre-2003, so the landscape has changed a lot. And then what to do in 2003, probably warfarinize again and maybe consider giving additional anticoagulation with Clexane as well. You may differ, perhaps feel free to comment. Then continuation of this case. So the patient had a sudden change in condition, as you can see, after receiving anticoagulation when she presented again. So she presented with this DVT, confirmed the DVT, and then they gave her IV bolus of heparin. She rapidly deteriorated with dyspnea, tachycardia, and hypertension, eventually requiring intensive care, monitoring, as well as intubation and IVC filter. I'm not really sure about that, even in the pre-2003 milieu. Nonetheless, the question arises again, what would one do? What is one thinking? What are the current problems? And I'll let you mull over it while we move on to the next case. So this is now the first patient in the series, 75-year-old gentleman who underwent orthopedic surgery for septic hardware. He also received anticoagulation of sorts post-operatively. And then shortly post-discharge, he presents again with a line-associated DVT. So yeah, once again, what does one think? So in 2003 again, based on this information, I'd probably not be completely sure. Perhaps fractionated heparin and a vitamin K antagonist again. And I think a lot has changed in the 20 years, but I think this is still an interesting case series. And then so then the clinicians ended up giving unfractionated heparin, and then catastrophe struck with this impending gangrene in his arm where he had this line-associated DVT of no normal platelet count. They gave therapeutic doses of Clexane. So the question again is, why is the patient worsening? What is the cause? I postulated perhaps phlegmasia ceruleus dolens. And then what would one do? Thrombolysis and then anticoagulate again? With what agents? And that brings me to the poll. I don't know if Gerdien is able to insert the poll at this point in time.
Sorry, Gideon, I didn't check my emails yet from Jock.
Oh, okay.
But I made him a co-host, Jock. You're supposed to be able to make a poll. Can you see the option?
I think from experience, it will take a little bit long to do it now. So I suggest we all have a quick look at this and either put something in the chat or just think about it. But I think to make a poll is going to take about 5-6 minutes.
No problem. Let's hope the audience, this audience is not aiming for options A and B. So I think on a serious note, I guess the options are C, D, E, and F. So the question then becomes, is the topic and what happened today, is it an issue of time and therapeutic range? Is it heparin-induced thrombocytopenia? Is it a discussion on thrombophilia and protein C deficiency? Or is it direct oral anticoagulants and the origins thereof? See, there is one comment in the chat, but perhaps we can give it another few seconds.
think D seems to be the one that those brave enough to answer is going for. So let's go with D.
I think Stephanie is answering in spite of attending the previous take on it, but nonetheless. So D is the correct answer. Heparin-induced thrombocytopenia being the theme tying these patients together, and then the presentation today. So just a few words on extracellular matrix proteins. So I took a random, rather thick, impressive looking book on cellular biology and extracellular matrix proteins. And within it, I searched on the page how many times heparin and heparin sulfates could be found. So in this chapter on extracellular matrix molecules, interestingly, you'll see heparin came up 12 times. On a search, heparin sulfate 11 times. So just a few words on the basic kind of biochemistry of heparin. So they form one of the molecules that are part of this group of extracellular matrix molecules. One of these then is glycoproteins. So the term glycoproteins denotes a carbohydrate and a protein in combination. Proteoglycans are then a type of glycoprotein. And what makes the proteoglycans interesting is they have glycosaminoglycans as the carbohydrate part of their structure as opposed to other carbohydrates. So heparin sulfate and heparin are types of glycosaminoglycans. The name is derived from the fact that the molecules were isolated from dog livers, hence the HEPA prefix to it. Glycosaminoglycans are imprecise molecules. And then also to note just a few other glycosaminoglycans on this picture here. So chondroitin, you might have heard of; keratin, you might have heard of; heparin and heparin sulfate, one might have heard of, as well as hyaluronan. So proteoglycans, as I said, protein as well as a carb, and then glycosaminoglycans being that carb. Just a few examples depicted in the drawing that I want to draw your attention to. So the aggregans, as you can see at the top here, they are present in cartilage. Hyaluron is present there, and its function is water trapping, and you can see the structure of the molecules would allow such. Syndecan, interesting to this audience, syndecan is present in mature plasma cells, and it's important for adhesion. Then the glypican, important in the hedgehog pathway, hedgehog signaling pathway, and adult stem cell regulation. So the glypicans and the GPI anchors are important transmembrane receptors. And then our subject of today, an anticoagulant via scaffolding, a short sequence of 5 modified sugars, and that would be heparin as well as heparin sulfate. A few points to highlight from this busy slide on proteoglycans and their expression. So just a few that are potentially relevant to this audience. So Sir-glycan contains heparin, can be found in white blood cells and mast cells, and it binds histamine in secretory granules. Glypican, 4 heparin sulfate chains present in the lung, skin, epithelia, endothelium, and smooth muscles. And I thought the Sir-glycan and glypican, perhaps in relation to anaphylaxis or anaphylactoid reactions, but I'll mention something about that later. The glypican also important in antithrombin. Syndecan also contains heparin sulfate, and it functions also within thrombospondin, which I'll also touch on a bit later. So that's my few words on extracellular matrix proteins. But that's probably not the end of the topic for me. And yeah, I think there's a lot to be learned within this field and potential fields for research going forwards. Just another example being the metalloproteinases and atherosclerosis being another area where one needs to kind of be very wary. And this whole development of medicine coming from the 4 elements and 4 humors to a mechanical age, to an anatomical age, then an endocrinological age, and now into this age of progressive and personalized medicine I think these extracellular matrix molecules, knowledge on that becomes the more prudent. So back to the culprit topic of today. On the left, a figure that the audience is, I'm sure, very well familiar with, and I won't review that. Just to quickly mention the heparin binding to the antithrombin, and the antithrombin having an inhibitory effect on factor 10 as well as on thrombin. The bottom, well, the figure on the right now actually changed things a bit, is where I want to lay the focus here. So just to note, the unfractionated heparin at the top and the low molecular weight heparin at the bottom, both of them contain a pentasaccharide sequence. The difference being this long glycosaminoglycan tail that basically separates the two. So the pentasaccharide basically binds to antithrombin, and the pentasaccharide, as I said, is present on both. So the pentasaccharide binds to both, though with unfractionated heparin, the long tail, the long glycosaminoglycan tail in unfractionated heparin also allows it to bind across to thrombin when it is attached to antithrombin, whereas the fractionated heparin does not have a long enough tail to bind the thrombin within the antithrombin and cause inhibition there. And that explains why unfractionated heparin has antithrombin effects on factor 10 as well as factor 2, and fractionated heparin only has antithrombin effects on factor 10. Then just a few more words on the pharmacokinetics and pharmacodynamics. So just a table on the different fractionated heparin agents, and this table just illustrates their mean molecular weight and the anti-10 to anti-2 ratios. And I guess the agents we would be most familiar with would be enoxaparin. Then just an interesting kind of question that I thought about previously, and the answer I came across in preparing for this discussion is why can one just dose clexane fairly willy-nilly based on guidelines, but heparin needs to be monitored closely, and it's not such a easy drug to work with. And it's due to the fact that the unfractionated heparin has this long tail, and this long tail can bind to a wide variety of other proteins, whereas fractionated heparin with its short tail is unable to do so. So the long tail allows this heparin to bind to an array of different proteins, and means that its effect is not saved for anticoagulation. And there would be a wide interperson variability, and hence we need to monitor heparin closely. A few other agents, so just again the diagram on the left with a unfractionated heparin versus the fractionated heparins versus fundaparinox, whereas you can see with fundaparinox there is no real glycosaminoglycan tail, and that, as mentioned previously, the glycosaminoglycan tail is made up of the heparins and the heparin sulfates, the long tail with the unfractionated heparin, and the shorter tail with a fractionated heparin. So that might explain partly why fundaparinox is not such a culprit agent in HIT. Then danaparoid sodium, I beg your pardon, is a combination of different glycosaminoglycans in their kind of pure form: dermatan sulfate, heparan sulfate, and chondroitin sulfate. And I think I actually skipped over the part where heparin, the difference between heparan sulfate and heparin is just the amount of sulfation between the two agents. And the mechanism of action with danaparoid is basically also through antithrombin activation. A few adverse effects of heparin: bleeding, and then heparin-induced thrombocytopenia. Skin lesions I'll briefly touch on, as well as bone disease, hyperkalemia, hyperlipidemia, and minor transaminitis I will not touch on in this discussion. A few words on skin disease. So the skin necrosis being the focus, and I'm contrasting it to warfarin. I think it's maybe the way I think about it or remember it, but I feel important to just contrast the two. So warfarin is due to thrombosis, so to heparin, the skin necrosis, but the mechanisms differ slightly. Protein C deficiency being mostly implicated in warfarin, whereas HIT has heparin-induced, well, the antibodies basically that activate platelets. And yeah, so with warfarin, there's often a hereditary deficiency. The sites also differ slightly. So the HIT skin lesions at least occur at the injection sites often, with fatty areas being a secondary area, and with warfarin, the fatty areas being the primary area affected. So other skin manifestations of anticoagulations, there's a myriad of them. This is just from UpToDate, but for the sake of time, I don't think we'll go into that. Bone disease, once again, contrasting heparin versus warfarin. So the data is not that strong in my opinion, and it's kind of circumstantial, not necessarily causal data. So the heparin from the UpToDate write-up, at least it says it may cause osteoporosis. Short-term low dose unlikely to do so. There are some bone turnover markers that are altered, the ALP coming down being deleterious. And once again, I question whether that relates to extracellular matrix molecules, as I said, the chondroitins, etc., being present and important in cartilage and bony material. Warfarin's mechanism of causing bone diseases. So I mean, it's basically via the routine mechanism of action how warfarin is an anticoagulant. So warfarin causes inhibition of vitamin K dependent GABA carboxylation of clotting factors, but it also causes this inhibition of gamma carboxylation of other components as well, like osteocalcin. So this gamma carboxylation is important for allowing calcium to bind, which allows the coagulation factors to basically act. So if there's no calcium there, they can't function fully. But a deleterious effect then is osteocalcin without calcium bound to it also can't fulfill its function within bone. And then there is some evidence, in my opinion, circumstantial regarding warfarin and bone disease. I couldn't come across a nice proper protocol and proper randomized controlled trials with it, but granted, I don't think it would be easy to perform anyway. So just basics on platelets that I'll quickly pass by. So platelets, as we all know, contain a variety of organelles, dense organelles containing serotonin and others, alpha granules containing platelet factor 4p selected thrombospondin and others. Just a reminder on the platelet function, so the sequence of events in platelet action relevant to the talk are then adhesion, and it's the subendothelium adhering to von Willebrand factor, which adheres to the platelet receptor, followed by activation, followed by amplification with release of soluble mediators, including serotonin, and then aggregation. So finally, to the topic of interest, heparin-induced thrombocytopenia. The nomenclature might differ slightly between topics, between write-ups, and especially in the past they used a bit of different terminology. So it's a life-threatening condition. It can occur at any dose, any schedule, any route, although with some, of course, more than others. Pathophysiologically speaking, it's due to antibodies directed against endogenous platelet factor 4 that complexes with heparin. And this then leads to platelet and endothelial activation with potentially catastrophic arterial and venous thromboses. A few questions remain to me unanswered regarding the immunology. Previously had a significantly high mortality rate, now much better with improved recognition and earlier interventions. And then I think certainly considerable financial and morbidity costs related to the overdiagnosis, though, now on the flip side to that coin of improved mortality. Just some terminology further, type 1 HIT, which pathologically is unimportant, at least. I think in terms of terminology and definitions within study sets, it could be a confounder. So type 1 HIT leads to no change in patient outcome. It's a common event. It occurs early. It's due to non-immune platelet aggregation because this heparin binds to glycoproteins and decrease, or glycoprotein receptors at least, and decreases the activation threshold, whereas type 2 is the subject of interest of today's discussion. Less common. It develops later. One gets a lower drop in the platelet count. It's antibody mediated, as I said, and the consequences are varied in contrast then to type 1. The timeline terminology of heparin-induced thrombocytopenia. This is then from up to date, but I'll just quickly guide you through it. Suspected hit. So it's basically where you get consulted by some discipline, so consultative haematology, and there's a reasonable suspicion of the diagnosis, but you don't have lab confirmation yet. So it's just a clinical call at this point. Then acute hit is confirmed heparin-induced thrombocytopenia via the usual measures, which I'll elaborate on later, and the platelets have not yet recovered. Then subacute hit A and hit B, these two are important in the management of specific patient populations. So I think generally one wouldn't be too concerned about those, but if you have these specific patient populations, we'll get to them later, then it becomes important. I mean, generally you just avoid heparin exposure, whether the patient falls into subacute hit A or hit B, or remote hit in fact. Then remote hit is a patient in whom the lab investigations were previously positive and now negative. So it's just a note in the patient's file. And I think it's important to make that note in the patient's file and tell it to the patient in the history. Then some hit variants. So this, once again, is an up-to-date table. And then some of my questions and comments in the margin that I'll also guide you through. So delayed onset hit, I find it questionable, and some of the authors also, as to how relevant it is and whether these cases were appropriately categorized, but I guess that's semantics. It's supposed to start after stopping the heparin. And yeah, the finer data I found shows that often it actually doesn't start after stopping heparin, but it was just missed. In the table, it says hit that begins or worsens, which I feel is a bit of a misnomer if we're going to say it's delayed onset. And it's definitively related to high antibody titers to this platelet factor 4 and heparin combination. Then refractory hit, I think it's fairly self-explanatory, but hit that does not resolve. And I think important to note that there is expected time to resolution is 7 days. And I think once again important to note the clinical milieu of the patient and to go look for other causes of thrombocytopenia if this supposed hit does not resolve in the way you would anticipate. Then spontaneous hit is fully fledged heparin-induced thrombocytopenia, but no heparin within the recent window that you can pick up. Interesting thing, I think, from an immunology point of view, is to note that preceding infections and surgery are common within these patients. And I postulate that perhaps it's due to antibodies that are binding to endogenous heparinoids, as I mentioned at the beginning, heparin occurring 12 times in a chapter of extracellular matrix proteins. Then fundaparinox associated ought to be rare, and that relates to the short or absent almost glycosaminoglycan tail. Severe hit with thrombocytopenia below 20 and bleeding, and I think once again one needs to think of alternative causes, because hit ought to not give you the severe thrombocytopenia. So perhaps things like DIC should cross your mind. Then another entity which I felt is not addressed within this terminology table is the presence of antibodies without heparin exposure and the hit syndrome. So I coined it antibody sign hit heparin exposure. It's kind of de novo, and once again I postulate whether that relates to extracellular matrix molecules. And I wonder if these patients with high titers get spontaneous hit, and it relates to neoepitope formation with antibody production via non-conventional methods, and I'll get to that a bit later. So just to kind of take us through, I was supposed to actually use those. Anyway, so a model for the pathophysiological mechanisms of type 2 hit. So step 1, as one can see on the left, the heparin that you've now, or the clinician introduced to the patient, that binds to the endogenous platelet factor 4. And these two then form a complex and bind to their cognate B cell and the B cells receptors, which then leads to antibody production. The antibodies then bind to this complex of platelet factor 4 and heparin, and these complexes then go and adhere to platelets and activate platelets. The activated platelets then secrete microparticles, which leads to a release of thrombin. Also to note that the endogenous heparin sulfate on the endothelial border, you've got platelet factor 4 that binds there, and the antibodies also go and activate the endothelium via those mechanisms. The antibodies also go and activate monocytes, and this basically leads to a cascade of events. More platelet activation leads to more platelet activation, and the same goes for the endothelium. So just a few words on antibody production. So as I said, it's antibodies directed against platelet factor 4 in combination with heparin, and it relates to a new antigen formation. So as you can see on the diagram on the right, one has platelet factors in the green that are on top of the platelets, and you've got the antibody separate and they don't bind, and you've got the heparin separate and they don't bind. But once you form this complex, then that binds to this antibody. This antibody then binds to the Fc receptor of the platelets, leading to further platelet activation and aggregation. Antibody formation in HIT is different to other drug-induced ITPs, in that the formation is primarily IgG formation, which is important. There's no primary IgM formation preceding IgG formation. The fact that the IgG disappears on your lab investigations does not mean that the patient is now safe. And it's also not always anamnestic. So sometimes you can give the patient heparin again and they won't react. Then just interesting to note that HIT antibodies occur in about 5% of the normal population. And 10% of this 5% will have a high antibody titer. And interesting to note that these antibodies are formed, or it's thought at least that these are formed due to T cell independent activation of B cells. So platelet factor 4 is stored in the alpha granules of platelets. Activation leads to release of this platelet factor 4. The function is to neutralize the heparins and the heparin sulfates on the endothelial surfaces, so that it can basically promote the coagulation cascade. It also acts as a chemokine in protection against infection. These heparin platelet factor 4 complexes, as I said, can also not just form on the endothelial surface, but also on the platelet surface. So antibody binding, so this is now where this IgG antibody binds to, I mean, in this picture on the left, it says pathogen, but for our purposes, then this complex of platelet factor 4 and heparin. So the IgG binds to that, and then it's the platelet Fc receptor then recognizes this antibody. Interesting to note, the platelet Fc receptor only recognizes IgG, and interesting to note a few things on this Fc gamma receptor 2A, which is now the relevant receptor in the platelets. So this receptor also occurs in a few other cells: neutrophils, eosinophils, monocytes, macrophages, dendritic cells, B cells, and then also basophils. And I thought the interesting ones, I mean, B cells, of course. Sorry, I'm not on B. That makes it difficult. So it binds to neutrophils, which I think is interesting in the pathophysiology, as well as macrophages and dendritic cells, which I think is an important point to note, and then platelets, of course. This in turn also leads to binding to the endothelial cells, which leads to activation and procoagulant changes on the endothelial cells. The antibodies also bind to von Willebrand factor, high molecular weight multimer strings of Willebrand factor complex with platelet factor 4, which then also promotes platelet binding and activation. So the pathophysiology of the specific clinical entities within HIT, so thrombocytopenia being often the important alert to the clinician, and the the postulated mechanism is, or mechanisms are consumption as well as sequestration. According to some authors, it denotes consumption being much more important than sequestration. There is a bit of discussion on that in the up-to-date write-up, as well as a few other authors, and I'll allude to that a bit later. So consumption happens via intravascular platelet activation. Therefore, more thrombocytopenia leads to a higher thrombotic risk. So if you drop your platelet count by 80%, you've got a higher thrombotic risk as opposed to someone who dropped their platelets by 60%. Sequestration and destruction via IgG-coated platelets that get removed by macrophages in the reticular endothelial system is the alternative explanation for the thrombocytopenia. Thrombosis also, so the mechanisms related are platelet activation, endothelial injury, which are issues that I've now highlighted a few times. And the activation occurs via the cell surface Fc gamma receptor 2A. These activated platelets then release also procoagulant microparticles. There's also binding to the endothelial surface via heparin sulfate, increased tissue factor and thrombin generation. And then the activation of the monocytes, like I said, the Fc gamma receptors also present on monocytes. And then reduced generation of activated protein C also being an interesting point. And just a note on the thrombosis, something that makes, or that should alert the clinician to HIT is arterial thrombosis that can occur with venous, or actually separately for that matter, which makes HIT a bit unique in that sense. Just the role of neutrophils within HIT. Once again, back to the Fc gamma receptor. So it can be, so the neutrophils can be activated directly as well as indirectly via this receptor. And this leads to activation of B-selectin and its ligand. Interesting point, and that comes back to the debate of what is the cause of the thrombocytopenia. Is it now the consumption or is it destruction? So there's a mouse model of HIT, and where they prevented netosis, which is a process of neutrophils. And there, by preventing netosis, they could prevent thrombocytopenia, or sorry, they could prevent thrombosis, but not thrombocytopenia. So the postulate from that is that thrombocytopenia and thrombosis are potentially separate events. Just a quick diagram, netosis, I won't go into that too much. There's too much other things to get through. The clinical variability of HIT, and I think this is really a fascinating point in the pathophysiology of it, and I think it still needs answers, or that's my feeling at least. And my first question is why don't all of us get HIT? I mean, if we have these heparin sulfates and heparins within our bodies, and we have platelet factor 4s, and we have this process that you can have T-cell independent antibody production, why does it only happen to some people, and why do only some people get thrombocytopenia and thromboses? So yeah, let's hope this slide can clear up a bit of that. So the variability is related to a few things. So as I said, it can occur at any dose, any schedule, and any route, though there is an issue with dose and schedule. So the term is stoichiometry, if I remember correctly, but it's basically related to this optimum ratio of heparin to platelet factor 4, and it's a 1-to-1 ratio. So if you overwhelm the platelet factor 4 with too much heparin, you decrease the amount of HIT that you get, and it's also the appropriate heparinoid agent. So unfractionated heparin is much more likely to cause HIT due to this long glycosaminoglycan tail, as opposed to other agents that have a shorter tail. Also related to the dose, the current, and that just adds to the stoichiometry. So the current rate with heparin flushes is quite low, as one would expect. With prophylaxis, heparin prophylaxis and therapeutic use, it's significantly higher. And then with bypass surgery, in which they give massive doses of heparin often, there's actually a decrease again in HIT incidence. which is explained by this stoichiometric phenomenon. The titer of HIT antibody may also influence the timing of HIT. So autoimmune HIT and the HIT variants, as I said, there are 5% of us walking around with HIT antibodies. Those with higher titers are more likely to present. And then the optical densitometry, which is something I'll get to a bit later, which is basically a quantitative measure of how much antibody binds. Then I think an interesting point, and I keep coming back to the Fc gamma receptor. So polymorphisms in platelet receptors and clotting factors is an important aspect in the clinical variability. There, I came across, or I was sent an article recently on ABO blood groups and their relationship to this polymorphisms within the Fc gamma receptor. Interesting to note that there is no HLA relationship, and I was wondering if that relates to the fact that this is T-cell independent. Then to kind of loop back to a point that I spoke on earlier is the issue of an increased incidence when there's systemic inflammation. You have a much higher rate of HIT when there's severe systemic inflammation, be that surgery or infection or whatever the case might be. I was wondering if that relates to danger signals in the immunological system that kind of leads to this T-cell independent antibody production. More common in women. I haven't really found an explanation for that. Then vaccine-induced immune thrombotic thrombocytopenia is a linked topic, not exactly directly related, so I won't spend too much time on it. But again, it relates to this recurrent neoepitopes. So once again, you have neoepitopes, and it relates to the adenoviral vector COVID vaccine specifically, where you have this recurrent and repetitive molecules on the surface, and that gets exposed to the antibody, and that leads to this T-cell independent activation, which is again the explanation for, or the current explanation for FIT and also then HIT, or part of the explanation at least. And here comes my befuddled look and my triple take on some of the immunology questions. So a few of them at least is why is there patchy immunological memory only? And as I said, the anamnestic response, why is it so patchy? I was wondering, is it because it is T-cell dependent in some and T-cell dependent, independent in some, dependent in others? Like I said, there are Fc gamma receptors on dendritic cells, so perhaps there's a link. So maybe there is some T-cell importance after all. Why? My second question is why does one get IgG with T-cell independent antibody production? It should be IgM. And then the other question is, why does one get IgG without first having IgM? And then just, I think this leads into a bewilderment of the species. Why does one have Fc receptors on platelets? And I mean, there's clear links between immunology and hemostasis and immunology and all the other systems, and just how complicated and interlinked we are. We think these receptors relate to immunology, but we talk about them in a hematology or any other subject matter for that instance. And interesting, just also, platelets are important part of the immune system in protection against E. coli via phagocytosis. So the incidence of HIT, occurrence in those that had been on heparin for 4 days, is about 5% according to the literature, which doesn't really fit our experience at Universitas Hospital, at least, and a tiny bit of math just to kind of explain this. So Universitas Academic Hospital, our hospital that we practice as, has about 400 beds on a thumbsuck. Let's say 25% are receiving anticoagulation, sufficient anticoagulation to cause HIT in a relative percentage of them. And that would mean that there's 5 cases of HIT, let's say, every week if we have full occupancy. And that's certainly not been our experience. At my guess, I would say we probably get 3 consultations for a query HIT case per month, as opposed to confirmed HIT cases. And my explanations for this were perhaps variances in HIT definitions by studies. Perhaps some of them were type 1, others were type 2. And then the mechanisms by which HIT was diagnosed in these case studies. Was it functional assays or antibody levels? Some of the studies actually just had a post-operative platelet drop, which I thought was a strange definition to have for HIT. In terms of risk factors for HIT, yeah, so once again, the epidemiological data is fraught with the same issues as per the previous slide. A lot of info on yes, I'll just quickly highlight a few issues. The data seem to suggest surgical patients are more at risk than medical patients. And interestingly, bypass patients don't have this impressively high HIT incidence. And again, I guess that pivots back to the issue of stoichiometry. Unsurprisingly, a second point is the issue of HIT being more common in the use of unfractionated versus fractionated heparin. Once again, the dose, no dose is too low, but there is a higher dose, kind of the therapeutic and prophylactic range, perhaps the therapeutic more so than prophylactic range. The female predominance not well elucidated. Age might be a risk factor, not really clear why. And then once again, the issue of the ABO blood group was found in a specific single nucleotide polymorphism in a genome-wide association study. So it's this deletion that basically puts one at a significantly increased risk with an odds ratio of 1.42. And it doesn't really relate to the A or the B or the O, but rather, once again, the FC receptors. And there are a few postulates in that article, but I thought that was quite interesting. Clinical manifestations, my not so unique take on the 4T score. So thrombosis, thrombocytopenia, timing, and other manifestations, and we'll briefly touch on those. The thrombosis is the second most common reason why people with HIT will present for attention, and it occurs in 25% of those who present. Staggeringly, though, 50% may get thromboses if they are not adequately anticoagulated. So I think that just emphasizes the fact that it's important to diagnose these people early and manage them appropriately. Venous thrombosis, 5 times more common than arterial thrombosis. But I think arterial thrombosis is an interesting and important differentiating factor when you are querying the diagnosis versus others. And then other thrombotic sequelae, death mostly via pulmonary emboli, skin necrosis, limb gangrene, and then other organ infarctions. The limb gangrene, I think, once again, arterial or venous via phlegmasia, cerulean dolens, and then the bleed, bleeding issues as a consequence of thrombosis, which I'll get to a bit later. Thrombocytopenia is the most common manifestation. And I guess the definition of thrombocytopenia is less than 150, but one actually just needs a 50% reduction in your baseline platelet count. One does not really need to go into pure thrombocytopenia territory. The typical or the mean nadir at least is approximately 60, and counts below 20 are quite seldomly encountered. And I think, again, one ought to go look for co-occurring conditions once the platelet count goes so low. The timing, the typical presentation is 5 to 10 days after initial exposure. There's a significantly shorter time lapse on second exposure. After your first episode of HIT, your second episode of HIT will occur much quicker after your heparin exposure. Antibodies occur within about 5 to 8 days after the exposure, contrasted to the 5 to 10 days where you actually get HIT. So it quickly develops from antibodies to actual HIT. The resolution of the thrombocytopenia, I think this is an important point to keep in mind. So your thrombocytopenia ought to improve within 7 days of withdrawal of your heparin agent. So I think, again, important to make sure that the patient doesn't get heparin flushes and so forth. And if your patient's platelet count doesn't start to improve after 3 to 4 days, you need to seriously start looking for an alternative diagnosis or an additive diagnosis at least. Early onset HIT, like I said, after a previous episode of HIT, can occur within 24 hours. Delayed onset HIT, once again, the onset being queried by me, is supposed to occur following withdrawal of heparin, and I wonder if these sometimes might not be missed, and it relates to high titer antibodies. Then bleeding, as I mentioned earlier, it's fortunately uncommon, and I think that's another thing that for clinicians standing at the bedside, if you're consulted for HIT and the patient is bleeding, you need to seriously think about alternative diagnoses, perhaps not just write it off, but bleeding ought to not be common in HIT. and I query whether it's due to the HIT per se, or is it due to the anticoagulation that you're using for the supposed HIT treatment. The bleeding occurs at unusual areas, most commonly gastrointestinal bleeding. The bleeding can also then occur as a dire consequence of a thrombotic event, specifically in the adrenals or intracranial hemorrhage, as per cerebral sinus thrombosis. Then my last T as part of other, so hypersensitivity reactions. Once again, I'm a bit puzzled regarding the immunology of it, whether this is actual anaphylaxis or whether this is anaphylactoid reactions. Seems there's not exactly consensus on it. Some say it's strongly related to IgG, others mention some IgE importance, others say no IgE. And then there's delayed type skin lesions at the site of your injection, and then there are a few others. There's quite a long write-up on UpToDate on this as well. So getting back to our cases, beg your pardon. In the picture, obviously, you can see a building on fire, and it's being extinguished while the American football match continues. And my feeling was this kind of fits to our cases that were described earlier. I beg your pardon. So just a reminder of patient 2 within the series. The case description on the left, 60-year-old female cardiac valve surgery. She got fractionated heparin, represented a month later with a DVT. One can appreciate the sudden deterioration after a second exposure. Her platelet count after the second exposure was 44, after initially being 420. And she had anaphylaxis rather than a pulmonary embolism. Interestingly, the authors note the transient amnesia that I touched on earlier to be a HIT-related event. And my queries, once again, with the case, and this is now said with a significant advantage of the availability of the retrospectoscope, is what did these clinicians hear on auscultation? Did they hear stridor or wheeze, or did they see any other features of hypersensitivity? And then also just, I found the IVC insertion peculiar. Why not kind of prove the pulmonary embolism before inserting an IVC filter? Anyway, that was published in 2002, so a lot has changed. Then a few excerpts from the kind of discussion on the article. There were 14 cases within this case series. 3 of them had normal platelet counts pre-discharge. 8 of the cases did not, or they did not check the platelet counts in these cases. And in 3 of the cases, there were actually abnormal platelet counts prior to discharge. And my take basically is not all delays are equal. An actual delayed HIT might not be as common. So this was one of the 2 cases. I actually removed one of the other patients that was from the other case series, but it was two case series from the Annals of Internal Medicine that were quoted on UpToDate. And a large portion of both of these case series actually had, I think, rather delayed noticing of HIT as opposed to delayed onset. And yeah, as I note you on the slide, is it delayed HIT, or is it actually just being unaware of your patient getting HIT? So the patient 1, which was our second case, 75-year-old male who had surgery for septic hardware, he got fractionated heparin post-operatively. He was readmitted with his line-associated DVT shortly after his discharge. And the authors discuss at length again here about the fact that, is this really delayed hit? And I found it interesting that they publish this as delayed hit, but they argue with themselves in it. And yeah, in a little excerpt from the article, in at least 3 patients, platelet counts had decreased 5 to 10 days after the start of heparin exposure, as is consistent with heparin-induced thrombocytopenia. And at the top it says, is this not rather delayed manifestation or delayed recognition as opposed to delayed onset hit? So getting back to, I guess, the important parts and the meat of the subject, really, the evaluation. So who should be evaluated for hit per the usual algorithms? So it's someone that has received heparin in the preceding 5 to 10 days. And I think just to remember the caveat of someone who's had recurrent heparin exposure or previous hit. And then it would be any one of the following scenarios ought to then trigger you: new onset thrombocytopenia or a decrease in count by 50%, new thromboses, necrotic skin lesions, and then acute systemic reactions like anaphylaxis. And I think very important, this is something to highlight, and I'll highlight it a few times again, one ought to not delay this consultation. One ought to give definitive advice at this point already. Thrombocytopenia often precedes thrombosis. If you can address the issue properly at this very point in time, you might decrease some thrombotic events. Just an overview of the approach, and I quite like it. This scoring system and algorithmic approach. I find it's a neat example of Bayesian theory and the use of nomograms in action. I'll just touch on that a bit later. The first step in the approach is the famous T-score that one can see on the right. For the sake of time, I won't really go through it at length, just to notice the T's being thrombocytopenia, timing, thrombosis, and then other cause of thrombocytopenia. Clearly note the stratification into risk groups of low probability, less than 1% chance of being hit, intermediate probability, and high probability based on the score that one calculates. And I think very important, just to circle back to the point I mentioned earlier, not diagnosing hit when it is present has very important thrombotic sequelae. And the flip side to that is incorrect presumptive diagnosis and investigation leads to increased bleeding and lots of additional costs, more expensive drugs, etc. The 4T score, getting back to that again, also has some caveats, like all diagnostic tools. But yeah, I think with a bit of understanding and pathophysiological nous, one could get far. And I think it's a good kind of screening tool to use in conjunction with clinical acumen. There are other tools like this HEP probability score, which I found quite cumbersome, and the data doesn't really show improved outcomes as opposed to the 4T score. Bayesian theory and nomograms, I won't bore anyone, or hopefully not bore anyone for too long on this after starting the talk about extracellular matrix molecules, especially on a Monday afternoon. But I think the nomogram just illustrates nicely the statistical, the kind of ideal clinical statistical decision making that one ought to have. So on the left, the axis basically just shows the pre-test probability, on the right the post-test probability, and in the middle is basically where you're going to, so you start off with pre-test probability on your left based on your score, how good your test is, and then you end up with the likelihood of this actually being the diagnosis. So just to kind of illustrate with an example, a low 4T score, as we said, has a pre-test probability of 1%. So if one moves to the 1% point, which is just above the red line on the left-sided line, and you have a good test for diagnostic confirmation with a likelihood ratio of 20, and one then draws a line through between the 0.01 and through 20, your post-test probability is only ever going to be 15 to 20%. So if you're sitting with a low pre-test probability, almost no matter how good your confirmatory test is, your post-test probability is probably still going to be rather low. So once again, just to highlight the importance of a good 40 score, you can really eliminate quite a few of these consultations, or not eliminate, but eliminate HIT as being part of the differential for the problem of the patient in quite a few of these consultations. The rest of the algorithmic approach to the diagnosis, I beg your pardon, which is once again based on Bayesian theory, is on the left. As you can see, when you get a low score from your 4T score, you need to look for something else, a different reason for why you were consulted, a different reason why the clinician was alerted, and you should not really pursue the diagnosis of HIT any further, although you should continue to assess the probability. So you don't completely discard it, but you don't pursue lab investigations further. And then anything higher, so intermediate or high probability for HIT, you need to consider as the patient having HIT until you can effectively prove that they don't have it. So that next step in your investigation, once you've reached the point of intermediate or high, is you need to then stop the heparinoid agent that you are giving. You need to give alternative anticoagulation, and we'll touch on that. And then you need to now confirm your diagnosis. And this next part in the lab confirmation will definitely depend on the setting and what tests are available. So I think it's important to stay in touch with your laboratory and your pathology services. And I think important just to note that these tests are not as simple as just it's portrayed here on the algorithm. They're not readily available. They often take a lot of time. They get batched, and with HIT, we're sitting in a potentially life-threatening diagnosis where it's you need to make decisions before the kind of week passes and you get your answer with a test. So you need to be brave. And you need to use clinical probability to aid you, and this algorithm I think aids one nicely. So there are point of care tests available. Scarcely though. We are quite lucky to have them available, and they have a very good and a very low negative likelihood ratio, so they can help you exclude some cases. So as opposed to straight doing an ELISA, you can do your point of care test and hopefully exclude a few more cases. But if you then don't have this, then you need to continue with your ELISA. Hopefully you can get optical densitometry that can then stratify these patients. So if you've got a very positive ELISA test result, you can once again confirm your HIT. If you have a very low ELISA optical densitometry result, you can once again exclude HIT and look for other causes and continue to reevaluate. And then you've got this gray zone where you need to move on to your next tier of tests. And we'll get to those shortly as well. I think just to get back to the point of knowing your diagnostic milieu, your lab, your pathologist, the tests that are available. This is an article recently published in the SAMJ, a few familiar names you'll see on the left. And basically the screening antibody tests are only performed in 2 public sector labs in South Africa. And the functional, I beg your pardon, assays are only performed in 1 lab, in a public lab, at least in South Africa. I'm not quite sure if things have changed in the succeeding few years. Just to quickly touch on the lab tests, the antibody tests, as I mentioned, the immunoassays. So they test to detect the presence of antibodies binding to platelet factor 4 and heparin complexes. Often, well, they can test for the whole set of immunoglobulins, but the one of utility really is the IgG. They do not, though, test the ability of the antibodies to activate the platelets. One does get commercial assays available, as you can see the picture on the left top. Unfortunately, though, these tests are often, the kits are expensive and the tests are batched. So it's not really viable to get an answer within a feasible, clinically, relevant time period. The private labs can, though, assist, fortunately, sometimes. And And then at the bottom, you can just, I don't think I need to explain an ELISA to this audience. Then a few additional steps one can add to your immunoassay. So like I've alluded to a few times, you can quantify the positivity of the test, which one would do via optical densitometry, which is basically just a quantitative measure of the optical density. Then that stoichiometry concept that I spoke about earlier is another way of reducing a few of your perhaps false positives. So you basically just dilute that platelet factor 4 and heparin ratio with the addition of lots of heparin, and that ought to alter the amount of antibody that you then see. And then you can also test specifically for IgG as opposed to other immunoglobulins to narrow your specificity. Optical density and optical densitometry and positive predictive value as in relation to the gold standard test. So back to the algorithm, with the optical densitometry of more than 2, you can basically confirm your hit. With the optical densitometry of more than, well, 1.5 and more with a high pre-test probability, you can also confirm your hit. And with a low score, you can exclude it. Anything else in between, you need to probably go look further. The point of care test, we've got this one available in our setting at Universitas Hospital in the Free State. It's a lateral flow test, turnaround time about 20 to 30 minutes. If one had the test available at the bedside, we do not, but it's relatively available. I mean, if you just call the hematopathologist, they are very efficient. I think we've gotten results in 45 minutes. So it's a very nice to have, and you can exclude a number of patients, because I think a lot of this is now my experience, at least, which I guess my anecdotes mean much less than others. But I think a lot of patients, especially if you go stratified and properly, will end up in the intermediate zone. And this lateral flow test really is quite helpful for those. Functional assays, like I said, the kind of the next tier to investigations. These are considered the gold standard diagnostic tests. One assesses the ability of these antibodies, and not just their presence, but their ability to bind and to activate platelets. So serotonin release assay was the original. These tests have some warts though, so they are quite costly. They need radioactive material, or some of them at least. One needs control samples, and these samples cannot simply be stored in the fridge. Just to illustrate our previous positive controls, we had 2 of them have both left the province. And the negative controls, fortunately, are easy to find. So these tests are often and routinely not available at most institutions, even in the developed world, and they don't really give time-yes results. And so they should be generally reserved for indeterminate immunoassays, or if there then happens to be discordance with a clinical picture. So there are a few options. Like I said, the serotonin release assay, which requires radioactive material. HIPAA, which is the test we do in our center and generally preferred in Europe as well, which is heparin-induced platelet aggregation. Then there's also platelet factor 4 dependent B-selectin expression, which is a relatively new kid on the block. And then there's also this thrombospondin release assay, which is even newer, published in an article in Blood a few months ago as well. I'll quickly just say a few words on serotonin release assay. Suppose, I guess it's all going to depend on which lab and what patient you test it on, but it has a reported sensitivity and specificity of 95%. One measures platelet activation by detecting the release of serotonin from these test platelets in the presence of patient's serum. I don't think there's much more to really be said about it. There's the interesting point of a cut-off dichotomy, where they said that perhaps it's the cut-off for positive versus negative that made a difference in the sensitivity and specificity of some assays. This was an interesting article that I came across that showed that, and this is a logarithmic scale, that you can pretty much make the cutoff anywhere, whether you put it at 20% or 50%, doesn't make much of a difference. Those that are positive will remain positive, and vice versa, or great majority at least. Then another kind of thought that crossed my mind that I couldn't nicely answer when preparing for this topic is the interference on the serotonin release assay that is mentioned. Interestingly, the only thing I could really come across was ticagrelor being an interfering agent. So it's a P2Y12 antagonist. It inhibits platelet aggregation. And my question was just, why not the other agents? Is it due to the fact that in the US, they don't like clopidogrel, and therefore they only really study ticagrelor, and in other settings, they don't use the SRA. So I wasn't quite sure about that. I thought that just an interesting point. The HIPAA test, the lab element to this is still way beyond me. So I won't spend much time on taking you through this and probably confusing you as much as I have myself. So one needs platelet poor plasma from the patient, and then platelet rich plasma from the healthy donors, and this is where your controls come in, and that's our dilemma at the moment. And you measure activation by checking aggregation in the presence of differing concentrations of heparin. This is from Dacey and Lewis, and cuvette 4 being the lane of interest at least. This is a big table I'm not going to go through, but I'll leave it in the slides. It's just the different functional and immunological assays that were available as per the writing of this article. A bit has changed, but I thought it was quite broad. Then new frontiers. Like I said, the issue with the controls makes the functional testing challenging. One can't just simply pop them in the fridge. This article published in Blood actually talks about the cryopreservation of these samples, which I thought is something worth exploring. Diagnosis, final few words. Once again, just to highlight the importance of pretest probability. The most harm can be avoided here by avoiding some thromboses if you expediently anticoagulate your patient, and then also if you can exclude those that don't have HIT from getting unnecessary changes to their anticoagulation recipe. And yeah, I think just understanding the lab element within the context of a patient is very important. Do you have rapid tests available? Do you have functional tests available? How long are these things going to take? And then to not be over-reliant on testing if these tests are going to take long. Differential diagnosis, I think it's going to depend on what the context is within which one is consulted. Thrombocytopenia within a admitted medical or surgical patient has a long list. The same goes for thromboses, and then anaphylactoid versus pulmonary emboli. So I think the usual approach to thrombocytopenia or thrombosis is imperative. Nearing the end at least. Management. So that this is now from an ASH pocket guideline that is downloadable, published December 2018. It's on the ASH website, which I think is quite handy. The dosing of the available agents are specifically listed here, as well as their mechanism of action. Argatroban is a highly selective thrombin inhibitor. Bivalirubin is a specific and reversible direct thrombin inhibitor, and it's a semi-synthetic hirudin derivative, which is from leech saliva. It's quite interesting. Fondaparinux I've already alluded to. That daniparoid sodium, as I said, is a combination of different glycosaminoglycans, which does not really contain heparin, but heparin sulfate. And I wonder if that's why it can be used in HIT. Dabigatran is a direct thrombin inhibitor, and apixaban also a direct selective reversible inhibitor of factor 10. I wonder if I missed a slide. Yeah, definitely. I think I actually deleted one of my slides by accident. But anyway, the deleted slide, I'll include it and update it. My apologies for that. So the deleted slide basically just gave the first step in the management of the HIT patient, which, as we've said a few times, is removing the heparin from the patient, or stop giving the patient heparin at least. The
yeah, and then one ought to switch to an appropriate non-heparin anticoagulant. So there's a few kind of clinical groupings. So critical, in the setting of critical illness, they recommend orgatroban or bilirudin. Clinically stable, one can consider fondaparinux or DOAC. In life or limb-threatening thromboses, one ought to consider orgatroban, bivalirudin, daniparod, or fondaparinux. I found that interesting that they don't mention thrombolysis in that setting. And then, yeah, that was kind of that from the missing slide, if I can remember. Apologies about that. Transitioning to an oral agent, I won't linger on that. Duration of therapy. So patients with thromboses and no other indications for anticoagulation need 3 to 6 months of anticoagulation. So that's your HIT patient with a thrombosis. If you don't find a thrombosis, you need to anticoagulate the patient for less than 3 months, according to this ASH guideline. Up-to-date authors say minimum of 4 weeks. But to note, HIT is one of the most prothrombotic states out there. So it's important to specifically screen these patients for thromboses. And some sources even suggest 4-limb sonography to screen. And I think scrupulous notes to avoid lifelong heparin flushes in bypass surgery, etc., etc. Special populations that I touched on earlier. So spontaneous HIT, the diagnostic algorithm does not change. In children, there's no validated algorithm, so you continue with the usual. Ticker-Gree law, you should probably use alternative functional assays. Patients on hemodialysis, fortunately, high incidence of clinically insignificant antibodies, and then the rate of actual HIT is fortunately fairly low, but you follow the usual algorithm. Patients with bypass surgery is specifically challenging. Heparin is almost always a key component in this procedure, and a considerable early post-op decrease in platelet count is almost the norm. This is up-to-date algorithm to working up bypass patients for HIT. I'll focus on ASHES. Renal replacement in patients with a history of HIT. So if you've got acute HIT, you basically continue per the usual HIT indications with anticoagulation. Thereafter, you wait for the platelet count to recover, and you use citrate in your HD circuit. And then I think, again, if your patient's platelet count does not recover, you need to use alternative agents like orgatroban. And then I think definitely just query why are the platelets not recovering. Heparin in cardiac and vascular surgery patients. So if there is acute HIT, you manage as per the usual indications. If there's not acute HIT, you need to define the phase, the timeline phase of the disease, which I guess pragmatically is not so simple. So once the functional test is negative, the options, so therefore it's a subacute HIT B. The options for therapy include you give heparin following platelet exchange, or then heparin with an added antiplatelet agent like tirofiban. So those are your two options there. If your functional tests remain positive, or I guess if you can't get functional tests in a timeous manner, you delay surgery if you are able to. If you are not, you either go for bivalirudin or heparin with pre and intra-op plasma exchange, or then heparin with tirofiban is also touted. PCI, percutaneous coronary intervention for these cases. So manage acute HIT per guidelines. Again, stratify into the phases of disease. If it's not acute HIT, subacute HIT B with negative functional tests. You can even use heparin if an alternative is not available. I query whether tirofiban is not an option here, because the cardiologists often use it anyway. And then if unable to defer, you use alternative agents like orgatroban, bivalirudin. And that's it. Thanks for allowing me to talk your ears off for the last hour and 20 minutes.
Thank you, Gideon. That was truly a deep dive, as we like to have on a Monday afternoon, and I think it was a fascinating to have a deeper insight into the into the underlying pathophysiology, which you very eloquently elucidated. So, and I just want to echo your comment that I really do find that ASH little booklet or rapid guide very useful, and it very succinctly gives you the management of HIT, and for those who don't have it, it would be worthwhile to check on the ASH website the link and get it. I made a few comments just there in the chat box, just surrounding the talk. Just maybe on the interesting thing for me, I mean, internally we had a discussion on surrounding the positive controls, and I didn't quite understand the concept of a positive control. I mean, what does it mean? And it actually essentially means it's those people where the anti-PF4 and heparin antibodies in their sample are actually able to activate their own platelets, and therefore sort of the next step is that those are actually people who are at risk of developing clinical HIT. So positive control should probably be, if they ever need heparin, should probably be sort of counseled that they should be monitored quite carefully when they receive heparin. I'm not sure if there's any other questions. Actually, Vernon also just commented on my comment that agatroban and bivalirudin is not available in South Africa, so we don't have that option. So we usually go for fondaparinux and a DOAC. I see Vernon said that that's the same in their setting. I could maybe make a quick comment on the cardiothoracic surgery. We recently had a patient where we needed urgent cardiothoracic surgery and had confirmed HIT, and eventually we decided to plasma exchange and use plasma exchange prior to surgery and during surgery, and use heparin during the bypass surgery, and then stop heparin immediately post-operatively. We managed it that way. I'm not sure if there's anybody else who's come across this challenging scenario. I see Simon has just sent a question. I think he sent directly to me. So the question is, have you come across the use of IVIG in HIT type 2? Is it only for autoimmune HIT? Giron, I don't know if you have a comment on the use of IVIG. In my understanding, it's only used in autoimmune HIT. I'm not sure if you came across any mention of that in your reading around heparin, the true HIT.
No, actually, also didn't come across anything specific. Just the exchange basically with true HIT.
Yeah. They do mention IVIG in that sort of pre-cardio. I think it is also mentioned as an option in pre-cardiac cardiac bypass surgery. So that may be one place. But in contrast to autoimmune HIT, where IVIG is part of the standard management, it's not part of the management of HIT. So Stephanie mentions just something interesting regarding the IVC filter in one case. Apparently they are not recommended in HIT as they can predispose to IVC or low limb thrombosis, including progression to venous limb gangrene. I think that's an important comment. I mean, my personal opinion regarding IVC filters is that, and this, they also have an increased risk of thrombosis, lower limb thrombosis outside of HIT. So the use of IVC filters should be really carefully considered, even in any form of thrombosis, and they should be removable, but it seems like the risk is much higher in HIT. All right, I mean, I see we are 2 minutes before 5:30. I'm not sure if there's any parting comments. If not, I actually thoroughly enjoyed your lecture, Gideon, and you really went in very deep. So well done on that. I see Vernon has unmuted. Vernon, do you have a parting shot?
Yes, thanks, thanks, Jock. There's a slide coming up that I want to show, but just before that, just to say that they seem to be using IVIG also in the emergency setting, or where you've got to reduce these antibodies around cardiac surgery. There is a 2023 paper specifically of managing these patients in the cardiothoracic surgery setting. So perhaps have a look at that. I can see if I can quickly grab the citation for anybody who wants to look at it. Just copy and paste it. It's published. Okay, here we go. It's going to be in the chat as now. There you go. So if anybody wants to just grab, copy and paste that for yourself, that might be of interest. It's for bypass surgery. Okay, then I just want to make you all aware that the World Transplant Games are currently taking place in Perth in Australia. There's quite a large contingent of South Africans taking part, with all kinds of solid organ transplant, but also with bone marrow transplant. If you go to there's a South African Transplant Sports Association. If you go to their website, you can actually download a nice list of photographs, and you might find that some of your own patients are on that list. It was quite nice to see. So keep an eye open on the Blood SA website. We will put links and more information there. So in closing, I just want to say, Gideon, fantastic job. Wow, what a deep dive. Jock, thank you for leading the conversation and for the insightful comments. For everyone who's taken part, really appreciate your being here. And we look forward to seeing all of you again next week. Have a great evening. Thank you. Bye-bye.
Thank you. Bye-bye, everyone.